This is Scott Holtstrand, and I am the PCMH Project Director at the South Carolina Medical Association. I want to welcome you to our fourth monthly webinar. This is the webinar for July of 2015. And I want to thank Claudia Cartledge and Jenna Rogers for their assistance in providing the information and details that are going to be discussed in this presentation. This presentation is going to be about NCQA's PCMH Standard 3. And Standard 3 is all about population health management. We'll be talking a little bit more about what population health management is and the benefits of it. And then we're going to look into each element of Standard 3. There are 5 elements. And we're going to be talking about what NCQA expects each practice to prove, and a little bit about how to go about proving each element in Standard 3. If you're interested in the other standards, we have recorded a number of webinars in the past months, and I encourage you to go to our website and view those as well. We've got a webinar on Standard 1 and on Standard 2. We also have a more detailed webinar that covers the must-pass aspects of each NCQA standard, in addition to some more general introductory information about NCQA and the patient-centered medical home. But for now, we're going to go ahead and get started on this month's webinar. And as always, if you have questions or comments, we encourage you to email at scotth@scmedical.org, scotth@scmedical.org. And we always welcome your feedback, questions, and comments. And if you email me at that address, I'd be happy to try to address any questions or concerns you may have. So let's go ahead and get started. The first question that may be in a lot of your minds is, what actually is population health? And this first definition is more of a technical definition, and I'm going to bring up a more basic definition in just a second. But if you read that with me, it's the health outcomes of a group of individuals, including the distribution of such outcomes within the group. Most physician practices have been working on and doing very well in individual health for many, many, many years. But now that we have more data capacity and we have EMR, and you can even do this without EMR, but because of all the data capacity that we've built into the medical system, we now can do more than just address patients as they walk through our door. Population health is an approach that thinks about patients when they're not even with us, and thinking about your whole patient population and their health and how you can take care of them. This is a very basic definition, but I think it gets the point across. Population health is caring for all of your patients, even when they aren't at your office. This is making sure that patients that you care for don't slip through the cracks for needed services, whether they be preventative services or chronic care services, or if there's medications that they're on that need to be monitored. Population health is about getting outside of the 4 walls of your practice so that you can make sure that the patients receive the high-quality care that they deserve when they're not with you, and also helping patients to help themselves when they're not with you as well. Some of the benefits of population health include being able to, on your end, proactively identify patients who need chronic or preventative care. In the past, it's so easy for practices to get busy and think that they're seeing everybody. And until you use your data and analysis capabilities through your EMR or otherwise, you may not realize that a lot of your patients who need services are slipping through the cracks. And so population health assists practices with making sure that all their patients receive all the care that they need. It also allows you to do outreach with your patients and to reach out to them when they need to know things that otherwise they wouldn't know. And again, without them having to come into your office, you as a patient-centered medical home are proactively reaching out to them so that they can receive the care that they need. And it also helps patients help themselves. You are able to provide resources and information to them when they're not with you, so that when they're not with you, they're actually continuing to take care of themselves and following the treatment regimens that you prescribe for them. And in an era when patient compliance is becoming more and more difficult, population health can assist with you helping patients position themselves to take better care of themselves. some other benefits of population health include your ability to monitor patient progress and track your performance of the way that you're caring for patients. The data that you collect and that you enter as you are performing your population health efforts allows you to get a feel for how many patients are we seeing for well checks. How many patients of our diabetics are actually getting their A1Cs checked every 3 months? How many of our hypertensive patients are getting their blood pressures checked at the appropriate times? You know, things like this are things that are very important, especially as payers are starting to reimburse you for how well you do with these quality metrics. Population health allows you to take that step back and ask yourself and measure yourself on the quality standards that are important not only for payers but also for the health of your patients. It also allows you to identify appropriate care plans for your patients, because when you know what your patient population is dealing with from a global perspective, it allows you to better plan and think through how we can care for large segments of our population. For example, if you look and see that you have a large asthmatic population or a large congestive heart failure population in your practice, it would enable you to cater or tailor your care plans towards those disease states. Well, let's now look just for a little while at the NCQA standards and elements for Standard 3. And as I mentioned earlier, there's 5 elements. This is element A. And the first 3 elements are really all about collecting information on your patients. One important aspect of population health management is that if you don't have data on your patients, then it's really hard to reach out to them for needed services or other things. And so the goal here behind these first 3 elements of Standard 3 is to make sure that you are collecting all the information that you can about your patients so that you can utilize that information to reach out to them for needed services, to keep track of what they need when they're not with you, and to basically get a better handle on your patient population as a whole, but also be able to drill down into specific items that you need. And I think as we go through elements A, B, and C, you'll find that you're doing most of this. And so this is more an exercise than just proving what you're already doing. And certainly if you're not doing all these things, we can help you think through how to integrate these into your clinical workflows. But I think, again, you'll find that most of this you're already doing. And so if you look at element A, this is all about the patient, just general demographic patient information that you're collecting. If you see numbers 1 through 5, that aligns with meaningful use. But it's my hunch that you're usually collecting date of birth, sex, and language, and probably race and ethnicity as well, and it's something that you would want to collect if you're not. Telephone numbers, email addresses, occupations, things like who their primary caregiver is, whether they have a guardian, whether they have an advance directive, health insurance information. You know, these are really more of the general things that your front office staff are probably collecting during intake. Some of this perhaps could be during rooming by one of your nurses, but this is kind of your generic basic information that most practices have been collecting on patients for years and years. And what you have to do to prove that you are meeting this element is you have to produce a report from your EMR that shows that for more than 80% of your patients during a certain time period, whether it be 3 months or a year, that you've collected each of these items. And if you look down to that box on the bottom of your screen, if for some reason you're not collecting all this information, you can still get all 3 points by meeting 10 or more of the factors. So you can give up a few of these and still get all 3 points from this element. 3 months of data is what NCQA is looking for. And for factor 14, they're actually looking for a documented process. Let me go back to factor 14. This is where you are collecting the name and contact information of other healthcare professionals involved in patient's care. So if your patient is a diabetic and they're seeing an endocrinologist, or if you're a child you're seeing has very severe asthma and they're seeing a pulmonologist, or whatever it may be, that you have a process in place for collecting that information, and then you show some examples of you actually collecting that. Numbers 1 through 13, though, it's just a straight-up report with a numerator and denominator, with the numerator being the number of patients that you've collected the information for, the denominator being all the patients you saw within a 3-month or more time period, and then your percentage needs to be more than 80%. This is just one example from NCQA that they've given that shows some of the factors from 3A. And if you look, this chart just shows, again, a denominator and a numerator like I've described for each of the categories, and then a percentage. And this is actually over a 4-month time period overall. And what this practice did is they broke each month down individually. There's no need to do that. And actually the way we do it is we'll just aggregate your time periods together into one report. 3B looks pretty busy here. It's a lot of information on this slide. But this is actually one of the easier ones to meet as long as you are working on meaningful use. All 11 of these align in some way with meaningful use stage 2. And so this actually is one of the easier ones to meet as long as you're meeting the percentage criteria that meaningful use is asking for. If you look, though, at number 6 and 7, 6 and 7 you can show with screenshots of how your EMR calculates and displays BMI or growth charts. And if you're in adult practice, you can just hit NA on number 7 because you wouldn't be doing the growth charts. So 6 and 7 are screenshots from your system, and then 1 through 5 and 8 through 11 is just a report. And actually on the next page, I'm going to show you what a report might look like. This is actually one practice we're working with right now. And we have not gotten the data yet on number 1 and 2, but the rest of them, as you can see, just has a numerator and denominator. It's a 3-month time period, April 1st through June 30th. And the percentages are meeting the NCQA and meaningful use requirements as indicated by the green on the very right-hand corner, or on the right-hand side of your screen. So this is an example of one of the templates that our organization has produced for your use. And when we were meeting with the practice, it was actually last week, we sat down with the individual that is running the project, and they read off the numbers, and we entered them into our templates that we've created, and we were able to produce what we think is a nice professional-looking template that NCQA will be able to easily follow, and we would anticipate that you get all the points for this. If you look down, though, in the bottom left-hand corner of the screen, you'll see that you can get all the points by just meeting 9 of the 11 of these factors. And so if you don't do all this or don't meet all the criteria, you can still get all the points, all 4 points from this category or from this element by doing 9 or 10. You do not have to do all 11. And then C, this one is actually a little bit tricky. And I'll explain why in just a second. But what NCQA is looking for here is what kind of information are you collecting on your patients? And if you look at the factors, they're asking about immunizations and screening, family, social, cultural characteristics, communication needs, and that's actually not language that they speak, but more like blind, deaf, or other cognitive disabilities that make it difficult to communicate. They want to make sure you're getting med history, advanced care planning, behaviors affecting health, mental health, substance use, history of patient and family, developmental screening for peds, that's like the MCHAT, depression screening like PHQ-9, and then an assessment of health literacy. Now, a lot of this you're collecting during your rooming. Your nurse likely or CMA will collect this information as you're rooming the patient. And that's not too hard to collect. What is a little more, and I said this is a little trickier, the trickier part of this is actually proving this to NCQA, the fact that you're collecting all this information. And what they want you to do is they actually give you 2 methods to prove this. The first method is doing a report with a numerator and denominator that looks at all the patients you saw in a 3-month period, and then the numerator would be how many patients you collected, for example, immunization information on. And then the denominator would be all the patients you saw during that time period. And as long as you meet 50% or more, then you pass that factor. The reason why that might be hard is that a lot of this is not in structured searchable data. And so if this is not structured data that you're collecting, you're not going to be able to run a report on that. And to build a template or something in your system to be able to collect that information and do it in a structured, reportable format may be not very cost effective. And so what NCQA has done is they've given an alternate way to prove this information. If you look at the information right after the blue "or," it says, review of patient records selected for the record review required in elements 4B and 4C, documenting presence or absence of information in record review workbook. We have not talked about the record review workbook yet, and we're actually not going to talk about the record review workbook until next month. In the August webinar, we will be talking about the record review workbook, and we'll likely even have a specific webinar only discussing the record review workbook, because it's a very important part of your patients that are in medical home process through NCQA. But just to give you a very brief overview for now, knowing that we'll talk more about it later, the record review workbook is something that NCQA gives you. It's an Excel file where you document the care that you provide to your high-risk patient population that you choose for Standard 4. Now, we have not talked about that yet, and we'll get to that next month. But just in brief, you are going to be selecting a small group of your patient, or a small subset of your patient population, to do additional care management with. And that segment of your patient population, in order to prove that you're doing this care management, you have to fill out the record review workbook. There's actually one other way to prove it that we'll talk about next month. But if you choose to do the record review workbook, what you do is you select 30 of those patients out of your high-risk population, and you do a chart review to see if you're providing certain types of care management for those patients. Well, when you're doing that chart review for those 30 patients, NCQA allows you for Standard 3C to use those same patients and check through their charts to see if you've done any of these 10 items for those patients. And as long as you've done any of these 10 items for more than 50% of those 30 patients, you would get credit for these factors. I know it's a little bit complicated, and we can certainly talk about it in person, or if you have questions, feel free to email me about that. But the bottom line is you're likely collecting all this information anyway, or much of this information, and so proving it will involve looking at your high-risk patients as they're coming through and doing a chart review to see if you've done any of these factors here. This next element is element D. This is our must-pass element. This is the one that we've got to get at least a 50% score on in order to pass your PCMH project. So 50%, if you look down at the bottom box, you've got to do at least 2 of these 5 things. This is typically one of the easier must-pass elements, and so I strongly recommend doing 4 or 5 of these. If you, again, look at the box on the bottom, you can get all 5 points from this element by doing 4. So I would suggest doing 4 or 5, and if you can, 5, just to have a little bit of buffer. But this one is actually one of the easier ones to prove, and I'll show you an example of how you prove these factors in just a second. Well, let's talk about what NCQA is asking you to do in element D. What they want you to do is they want you to use all that data that you've been collecting on your patients to determine those patients of yours that have missed important appointments or missed important screenings or chronic care services, and then proactively reach out to those patients and ask them to come on in for a visit so that they can get the services that they need. And that reach out can occur in any way you deem appropriate. You could do an email, you can do a phone call, you can do a letter, a postcard. Whatever normal way you reach out to patients, you would reach out to your patients in that way. And so what you have to do is, from your EMR, you have to, or from another, if you don't have an EMR, from your practice management system perhaps, you've got to print or produce lists of patients who are eligible for certain services but have not received those services. For example, if you look at number 1, you've got to pick at least 2 preventative care services. So a lot of adult practices pick colorectal cancer screening and mammograms. And so what you would do is, let's just use colorectal cancer screening as the example. You would look at all the adults over the age of 50 in your system for whom you do not have evidence of colorectal cancer screening, whether it be a colonoscopy in the last 10 years or the colorectal cancer screening cards within the last year, depending upon the method that you and your patient have chosen. But then your EMR would produce a list of those patients that did not receive the needed screening, And then you would use that list to reach out to your patients and ask them to come in for those services. If you've ever heard of a gaps in care report, essentially what you're doing is producing your own gaps in care reports and then reaching out to your patients for needed services. This can also be, in slow times in your practice, a volume generator. You are bringing your patients in for services that they really do need, and so it's a legitimate way to reach out to your patients. And then if you look at number 2, immunizations, a lot of times in adult contexts, they pick a pneumococcal vaccination and the flu shot. Childhood immunizations are much more frequent. They may pick flu shot, Tdap, HPV, MCV. You really have a lot of choices there. But again, you would print out a list. Let's just say it's HPV of all your children age 11 to 14 that have no evidence of receiving the HPV vaccination. And then the children on that list, you would reach out to their parents and let them know that it would be important for them to receive this immunization. Then if you look at number 3, chronic care or acute care services, again, this is not rocket science. It's a lot easier on the adult side because there's so many chronic care services. You know, if you have a diabetic, they may need an A1C, they may need their LDLs checked, they may need a foot exam, they may need a retinal exam. On the child side, usually it's going to be an ADHD follow-up or an asthma follow-up or an obesity care follow-up, something like that. And again, you're doing the same thing. You're printing out lists of patients who have missed receiving needed services, and then you're reaching out to them to let them know of their need to receive those services. Number 4 is patients not recently seen by the practice. What we usually recommend, and there's a lot of ways you can go on this, but what we recommend typically is you print out a list of patients who have been seen by your practice in the last 2 years, but have not been seen in the last year. And by limiting it to 2 years, you're limiting it to patients that have been at least in your practice relatively recently and maybe still affiliated with your practice, but then have not been back for an annual well check in a couple of years. And then the 5th category is medication monitoring or alerts. The easiest example of this is if there's a medication recall that's announced by a pharmaceutical company, you would produce a list of all your patients who are on that medication and then reach out to them. But that doesn't always happen while you're doing your NCQA application. So there's other things you can do. You can reach out to patients who are on medication with severe side effects to just monitor them, make sure that everything's going okay. You may want to, you may have other ideas about medications that you would like to have information from your patients on or alert them to certain things. Or, for example, if there's a medication that could result in a higher cholesterol levels, you may want to reach out to your patients on that specific medication to remind them to come in for their cholesterol checks every 3 months or however often they're supposed to come in. And so this one, it's actually a very effective way to show your patients that you're really caring for them. You are reaching out to them proactively and letting them know that you are aware of services that they need and that you're following their care and wanting them to receive the best care possible. And so this is just a summary of what I've just said. You produce those reports or lists of patients needed and who need the services, and then you just produce material showing how each service, how patients have been notified of each service. I'm just going to give you one example. There's just so many ways you can do this. This is from a practice that used eClinicalWorks, and they used a registry. And if you look kind of, it's a little faded, but if you look in the middle of the page, they looked at the CPT codes for a well visit for children, for 11-year-old well visit, and they narrowed the age range to 11. And what they were trying to do is find all their 11-year-olds who had missed their 11-year-old well visit. And then they produced the list. You can see that it's been de-identified, so you can't see who the patients are or their date of birth. But using this list, the practice then sent an email. This is the email script to let them, it was a well child exam and a Tdap vaccine. So this was the Tdap vaccination that the practice was looking for. And then the practice just shows NCQA the email script that they used to let them know about the Tdap shot. And that's all you got to do. And so it might not be an email, it might be a phone script, it might be a letter, it might be some other method of reaching out to your patients. I've even had practices that use text messages. So it's up to you how you want to reach out to your patients. But to prove to NCQA that you're doing this, all you have to do is produce that list, obviously de-identify it, and then you're going to send or produce the script or text of the reach out that you used. And then standard 3E, this one can be somewhat confusing until you understand what it is. And once you do, it makes a lot of sense. This is where NCQA wants you to implement point-of-care clinical decision support based on evidence-based guidelines for conditions that are important to the care of your practice. So what does all that mean? What that means, let's just give an example. So number one, NCQA wants you to pick a mental health or substance use disorder. So if you're in peds, you might pick ADHD. If you're in adult practice, you might pick depression. So let's just say you pick depression. So what NCQA wants you to do is show how you have in your system, whether it be your EMR or on paper or some other method, you have evidence-based guidelines for the care of depression integrated into your clinical workflows, whether it be on your computer or on a paper chart or something else, so that you get point-of-care reminders of what you should be doing to care for that patient while they're there. Again, based on what evidence-based guidelines suggest the best care should be. Let's look at number two, chronic medical condition. Let's say you pick diabetes. So it would be natural to have some kind of flow chart built into your EMR. And let me say, a lot of EMRs already have this integrated, so this won't be something you'll have to recreate or create. But you'll have a flow sheet in your EMR that makes sure that you've done the A1C test, to make sure you've done microalbumin, to make sure you've done LDL levels, to make sure that the patient's had their retinal exam or their foot exam. All the things that evidence-based guidelines suggest should be involved in the care of a diabetic is up in front of you. It's called clinical decision support that happens at the point of care. So this is not something that pops up after the patient leaves. This is something that would be serving as a reminder while the patient is still there. And again, many EMRs already have this integrated into their systems. And so what NCQA wants you to do is for each of these factors, pick a condition that's important to your practice. So an acute condition, you would pick something that your practice frequently deals with, otitis media or pharyngitis if you're a peds practice. Or on the adult side, it could be something related to migraine headaches or gastroenteritis or something else, or bronchitis, something that you commonly see, upper respiratory infections, sinus infections, whatever. A condition related to unhealthy behaviors. For that one, you might want to pick smoking or obesity, something that is pretty common to your practice where there are evidence-based guidelines for the care of that condition. And then well child or adult care. In peds, Bright Futures is what a lot of folks use for those point-of-care reminders. And adult care, there's a lot of resources out there for providing like a well woman visit or a Medicare wellness visit, lots of things. And then the last category is about overuse and appropriateness issues. And this one may be a little trickier. Your practice may not, or I'm sorry, your EMR may not have this built in. But this would be something like the overuse of prescribing antibiotics for pharyngitis, and where a trigger would come up reminding you to do a strep test before you prescribe antibiotics. There's all sorts of things out there that maybe evidence-based guidelines have changed on. Like I know that CBCs for children was changed a year or two ago, where you're no longer supposed to do CBCs for every child at age 4. And so there might be a reminder in your system that is, if you do an order, that would ask you certain questions about whether that order was absolutely necessary. Again, this one is probably one that's not going to be in your system. But even if it's not, you can get all 4 points from this by doing 5 of the 6. And so this is something that's more on a case-by-case basis. We're happy to come and look at your system and look at your workflows and see if you've already got these kind of point-of-care reminders built in. And if you do, all you have to do to prove this is show NCQA that you show them the condition that you've chosen, the source of your guidelines. So let's say they're diabetics in the American Diabetic Association, or if they're an asthmatic, it might be the American Lung Association, or if it's WellCare, it might be the Bright Futures from the American Academy of Pediatrics. So you show them the source of the guidelines that you're using, and then you just show examples of how those guidelines are actually implemented. into your practice workflows. Here's just a couple examples that NCQA gives with respect to evidence-based guidelines built into workflows. This is a diabetes flow sheet. If you look down the left-hand column, it's got many of the evidence-based guidelines for what a diabetic should receive and then how often those services should be provided. And this just serves as a good reminder to make sure that you've done everything that you're supposed to do for your diabetics. Here's another example from an EMR, which has a lipid management screen. This just has evidence-based guidelines that are built in for how to make sure that you are prescribing and caring for your patients who have lipid issues. And then here's an asthma guideline worksheet. It's kind of hard to see that, but this is basically a visit sheet that just has all the kinds of reminders for what you're supposed to do for treating asthmatics. And as y'all know, there are so many different types of conditions that you're treating, so many things you're supposed to be doing for them. Evidence-based guidelines are changing all the time. This is a good way to make sure that you're not letting something slip through the cracks. It just serves as that point of care reminder just to make sure that you're doing what you should be doing for the care of the patients. Well, I know that was a brief overview, but I hope that it gives you a good feel for what Standard 3 is all about. Standard 3 is about population management. It's about collecting that data. It's about caring for your patients when they're not in your office by sending them reminders of gaps in care that they've got, and then about implementing evidence-based care into the care for large segments of your patient population who have conditions that you believe are important for the treatment of your patients. Well, stay tuned for next month as we're going to be going over Standard 4. Standard 4 is very important because this is the one that involves the most interference with your clinical workflows. Standard 4 is one of those that it's likely you're not doing everything already and you're going to have to introduce some new items into your clinical workflows. And it's also one of the more complicated to just to think through and to implement. So I definitely encourage you to come back for our August webinar about Standard 4. And that's also the webinar where we'll be introducing the record review workbook. So that's going to be a very important one for you to consider. And until then, if you have questions or comments, you can email me at scotth@scmedical.org. And until next time, I hope all is well with y'all and look forward to connecting with y'all in August. Thanks.